This next presentation is a joint presentation by myself and Jean, but before we start, can I have a show of hands, please? How many of you were present during the 2004 to 2006 outbreaks of Clostridium difficile in England? Hands up high, old eyesight. Just a few of you, thank you. So we recognise that over time, learning experiences are lost. But this year is a critical year, in our view, for infection prevention and control, and a huge opportunity. It's also an opportunity to reflect on the last 20 years. So Jean, as my infection control doctor at the time, is going to talk about the learning and the experience of Stoke Mandeville, and I'm going to reflect on more recent events with the COVID-19 inquiry. So what are we going to talk about? Well, just very quickly, I'm going to give you some context and background, because this is really important, particularly when it comes to the COVID inquiry. And what this presentation isn't is a forensic dissection of the current COVID-19 inquiry reports. It is about reflecting on some of the key recommendations and findings from the report, because these have implications not just for pandemic planning, but also for business as usual infection prevention and control. And if time allows, I will look back to when I last spoke in 2024 around what it meant to have the nursing elements of infection prevention and control, and bridging that knowledge theory gap. So I just want to start with what is an inquiry. You'll all be familiar with hearing about inquiries on the news, whether these are health-related or not. Some of the most recent non-health-related inquiries include things like the post office scandal and the post office inquiry, but also other inquiries such as the Bloody Sunday inquiry. And the purpose of an inquiry is to establish the facts in terms of a full and fair account of what happened, to enable learning from the events. They're also an opportunity for catharsis of those involved and those impacted on by the events that took place. But the focus is very much on learning. What's a public inquiry? What makes this different? Well, a public inquiry is established by a minister, and really to set up and understand what happened and to have learning as a result of that. And there are statutory and non-statutory inquiries. Statutory inquiries are set up under the Inquiries Act 2005, and the UK COVID-19 inquiry was a statutory inquiry led by Baroness Hallett. They are non-adversarial, and that means essentially that they are not looking to apportion guilt, although, having said that, you can feel that guilt or blame is being apportioned to you as part of that process, but it is not about finding people guilty or not guilty. It is about ensuring through collaboration that the terms of reference are delivered and the shared goals of all those involved, which in the case of the COVID-19 inquiry is to ensure that we have appropriate and adequate pandemic planning for the future, are met. So what's the difference between an inquiry, an investigation, and an inquest? And any one of you here today could be involved in the future in any three of these situations. So I've just described a public inquiry. Investigations often follow a similar process to inquiries, but they are less formal. But the outcomes of these are always to determine learning and to understand what happened so that events don't reoccur. A coroner's inquest is very similar to a public inquiry in many ways. Coroners have significant powers under the Coroners Act 2009, and as with a public inquiry, they can summon witnesses and documents to establish the cause of events that led to a death. They can also have the powers to enter premises and to exhume bodies, for example. So IPC-related investigations, of which there have been many over the years. I've just listed a few examples here that I thought might be of interest to you. And one, actually, interestingly, the first one, the 1978 investigation into the smallpox incident at Birmingham, is one that still crops up in conversation even today. And Jean and I were talking about that not that long ago. And this follows the death of Janet Parker, a medical photographer at Birmingham, and the investigation led to the subsequent shooter inquiry, which had significant implications for the storage of dangerous pathogens. And the others are listed there. You'll see the 2025 investigation by the National Audit Office into how the government is achieving its aims of the National Action Plan for Antimicrobial Resistance, and also more recently the DARSI investigation into the state of the NHS, the recommendations of which were fed into the development of the NHS 10-year plan. So it's all about learning, it's all about recommendations. In terms of inquiries during my professional lifetime, which actually when I look back is quite long now, the Stanley Royd inquiry in 1978, in which 19 patients died of salmonella, led to the removal of Crown immunity from NHS premises in terms of catering. And there have been a number of other inquiries since then, some of which may be familiar to you. And you will see a number relating to Clostridium difficile. Several inquiries are ongoing, including the UK COVID-19 inquiry, and the Scottish Hospitals inquiry is one that I would urge you to watch as well, because this has significant implications as IPC practitioners for the built environment, whether you're involved in the building, refurbishment or commissioning of environments. All of the inquiries have implications for systems, for governance, and for IPC practice. And now I'm going to hand over to Jean to talk you through what happened between 2004 and 2006 and the learning.
Thanks very much, Rose. Sorry for the delay in my appearing here. I managed to crack C. diff, but I couldn't crack Birmingham roundabouts. Yes, so I've been a consultant microbiologist for 30 years, and the first 10 years were relatively fairly okay, but in 2004, unfortunately, we had a massive outbreak of Clostridium difficile in the hospital. So up till then, we had a few sporadic cases of C. diff, but there seemed to be something different about this. There were dozens of patients involved, multiple wards, several deaths, even in some young people. It was really strange. Even the surgeons were noticing that some of their previously healthy patients were dying post-operatively from C. diff. So it was really disturbing and unsettling. So between October 2003 and June 2004, we had a large outbreak, as I say, at Stoke Mandeville, with 174 cases over those 9 months and 19 deaths that were directly attributable to C. diff. That came to an end fairly slowly, and then the following year, October 2004 to June 2005, we had a second outbreak. So there were 160 cases this time, and again 19 deaths which were attributable to C. diff. So we did send our strains for typing, which in those days was fairly unusual, and we found that there was a very unusual type found, which was type 027. So this had only been found once or twice in the UK up till then. The first time it was found was in 1999 in Preston, and then the second time was in Birmingham, actually in 2000. But meanwhile, in the United States, they were having a huge epidemic of C. diff due to a strain they called NAP. And in Canada as well, there was another strain that was causing a massive outbreak. So I asked the anaerobic reference lab, could there be a similarity between our strains, and when they looked at them, they found they were all identical strains, so the American and Canadian strains were the same as 027. And this was a hypertoxin-producing strain, which was found to account for the severity of infection in the patients and the high death rate as well in this particular strain. So then in May 2005, there was a local article in the Bucks Herald near Stoke Mandeville about somebody who died of C. diff. So that was the first time it got into the press. And then in June, there was the huge front page in The Independent about a new superbug. And it got into the news. It was on the BBC headlines. I was going around with a paper bag over my head, trying to pretend I wasn't from Stoke Mandeville. But it was, it was awful, really. The publicity was absolutely massive. And in that month, the Healthcare Commission inquiry was requested by the Secretary of State. The Healthcare Commission had just been set up in 2004. It's since been replaced by CQC in 2009, so this was like the precursor of CQC. And so they came in September 2005 and stayed until April 2006. They interviewed over 200 people. They looked at over 1,000 records and policies, etc. So it was, very intensive and very thorough, I must say. We were very impressed by, how well they performed. They were there during lots of clusters of cases of C. diff. They visited all the areas of the hospitals, so they did a very good job. So this was like our fairly primitive outbreak curve. We had 2 outbreaks, as I say, of the same strain. What actions did we take? We decided to obviously restrict the use of broad-spectrum antibiotics. So initially we removed Coamox, Amox, clindamycin and cephalosporins from drug cupboards on the wards. We used hypochlorite disinfectant, and we created a cohort area where we were able to nurse all the patients together. So that did seem to work initially, but then we had the second outbreak, and this time, because we knew that was type 027, which had a link with quinolone use, that's supposed to be really why that developed initially, we decided to take away ciprofloxacin as well. And we did use hydrogen peroxide vapor, and this time we actually had set up a full C. diff ward where we had about 30 beds for our C. diff patients, and we did regular ward rounds with gastroenterology, etc., and that did seem to do the trick. So you can see in 2004, 2005, our rates were above the average, but we did manage to control it very well, whereas 027 then appeared really in most trusts in the country around that time. You'll see a few familiar faces there. Rose, our excellent infection control nurse. So a group of us went to Montreal because in Montreal they had experience of this strain and they had managed to control it very well, so we thought we'd learn the lessons from them. So the person standing next to Rose is Vivian Liu, who was the lead microbiologist at Montreal General Hospital, and we were also accompanied by the lead nurse consultant in health protection from our area, who was very involved with the outbreak, and our director of estates, which actually was very useful because I think the cleaning, obviously, of the environment is absolutely key. And then there was the lead infection control nurse from Montreal as well. So this shows the serogroups of C. diff going from 2008 to 2023, and that nice blue color about halfway down is type 027. So you can see that it was probably the main strain in 2008, but by 2015 it had disappeared really. So since then, other strains have become probably more significant, but the big blue bar there, sort of the second from the bottom, is other strains. So there's obviously been a mixture of lots of strains since then, but it's interesting how these patterns of strains develop from time to time. So the Healthcare Commission produced their report in July 2006, and these were the main findings that they found. So they felt that the environment was very poor for caring for patients. They were mainly Nightingale wards with very few side rooms. They found poor practice in the control of infection, like lack of isolation facilities, as I say. And a very key point was that senior managers really were ignoring the advice from infection control, and they were giving all their attention to other strategic priorities. Governance was dysfunctional. The DIPSI at the time was a medical director, and he wasn't actually taking infection control reports to the trust board, so there was a sort of lack of knowledge by the trust board about what was going on. Insufficient hand wash facilities, antiquated bedpan washers, and IPC advice, as I say, was being overridden. This was all in the report. So on the left there you can see the recommendations for our hospital for Stoke Mandeville. So patients should be rapidly isolated, patient movements should be restricted, outbreaks should be identified fast, quick, multidisciplinary outbreak committees should be set up. This all is fairly obvious, but at the time C. diff really was a sort of Cinderella infection. MRSA was really all the rage, so nothing was really being done actively about C. diff. And then, that there should be regular review of all the components of outbreak management, and there should be, good communication with patients as well and the public, because at the time people weren't really being told much about what was going on. Infection control should be routine for all staff, and I can't believe this, that training wasn't mandatory at the time, training in infection control for clinical staff, but that was brought in. And obviously we needed to improve risk and management and clinical governance. So there was a huge impact on the trust board, so I can tell you that infection control was taken seriously. I think it's, once it got into the public domain. So the report said that the trust board demonstrated significant failures and the safety of patients should not be compromised under any circumstance, and they recommended that the leadership must change, but the chairman and CEO stepped down sort of on their own anyway. It was obviously a very traumatic time for the infection control team, and this really hasn't been explored very much. We were felt to be, we were respected by the hospital, and luckily that came through in the report as well. But we did go through an awful lot of stress, and I think, Rose, we used to have sort of regular coffee breaks, used we, and sort of meet up weekly for lunch and just try and keep each other going. So there was significant strain. But I think the outcome actually was very positive in that there was lots of new guidance produced, and I think IPC became a lot more respected generally in the trust. And then the year after that, there was another Healthcare Commission inquiry, this time into Maidstone and Tunbridge Wells, another C. diff outbreak. So that was published in October 2007. So there were sort of similar factors again, lack of leadership in infection control. There was a poor outbreak policy, poor control of antibiotics, delayed sending of samples. So these things are still found, I think, in outbreaks nowadays. So they did mention in the Maidstone and Tunbridge Wells report that probably there hadn't been learning from the Stoke Mandeville one, and there were some common factors identified for both. Both had gone through difficult recent mergers of hospitals. The trust board was preoccupied by finance. I'm sure that hasn't changed a lot. So there was a very demanding agenda for reconfiguration and PFI as well in both of these hospitals. And both of them had lots of Nightingale wards, few side rooms, unacceptable examples of contamination, and low levels of nurses due to financial pressures. So as I say, there was a positive outcome in the end. So I think there was an increased focus on clinical safety over financial and other strategic objectives. And C. diff was finally recognized as an important disease in its own right. There was recognition recognition of vulnerability of infection control when not addressed or maintained as a priority for patient safety. The code of practice came in after these inquiries in 2006, and the importance of leadership and narrative came to the fore. I think hospitals became cleaner, antibiotic prescribing gained a new importance, and I think infection control as a whole, became a lot more important for everybody.
Thank you, Jean. So that was the experience in 2006, and if any of you ever find yourself in really difficult, stressful situations, I thoroughly recommend a Wednesday team lunch, because it means you've made it halfway through the week, and that really keeps you going. So now to more recent events, and there are similarities, thank you, sorry, dry throat, similarities in some of the experiences with COVID-19, two completely different situations, but some common themes. And the impact on IPC staff in particular, which I will refer to more in a minute, definitely is one that needs exploring as we move the lessons identified forward. And it's a huge opportunity for us to take. So first of all, just to reinstate, the UK COVID-19 inquiry is a public independent review of the pandemic response. It's not an investigation into infection prevention and control. However, infection prevention and control, of course, was absolutely critical and vital to the response. The inquiry has published reports to Module 1, 2A, B and C, 3, and most recently 4, which is on vaccination. We're expecting reports on Modules 5, procurement, and 6 on care homes to follow over the next few months, and there will undoubtedly be implications for infection prevention and control when they are published. So this is all about learning, even the hard lessons. This wording is taken from the inquiry, and for me, it sort of summarised and described where infection prevention and control sat. So this for me is about the ripple effect and reminding me that in an extreme situation, even in business as usual, of course, this is not just about hospital care, it's about wherever health and care is delivered by healthcare professionals in multiple roles. And it's also about understanding the lived experience of those as the recipients of IPC practice and guidelines. So I thought, because of limited time, I would just focus on one finding and one recommendation. There are multiple recommendations throughout the Module 3 report, and these are the words of the inquiry. And they noted three what they called fundamental flaws in infection prevention and control that led to increased risks. Now, we've heard from Jean about multiple flaws that existed at Stoke Mandeville Hospital. So these are flaws that we can now address in the context of respiratory infections, particularly those in a pandemic situation. Now, the recommendations are to inform future pandemic planning and management, but there are clearly opportunities there for business as usual infection prevention and control. Avoiding lessons repeated. I actually make a conscious effort all the time to not refer to lessons learned. As a military wife of many years, we talk about lessons identified in that context, because you have to identify the lessons before you can implement the changes and assess whether they have been actioned adequately. But avoiding lessons repeated is something that we really need to take to heart. And you've heard around criticism from Mason and Tunbridge Wells that didn't learn the lessons from Stoke Mandeville. And there are multiple examples where we know what's happening or what happened, and we haven't actually initiated actions from previous incidents. So Lessons learned can be described as hollow or vacuous language that we need to avoid. We absolutely, every single one of us here is part of the system, and we all need to play our role in terms of making sure those lessons are identified and that we put in place actions to support improvements in infection prevention and control and to strengthen the infection prevention and control speciality. Baroness Hallett's made it very clear that she alone, although she will make her recommendations to government, is not responsible for their implementation, and ultimately the recommendations do lie with the government, and the government has 6 months to respond to the Module 3 report. They've responded to Module 1, and it will take time to see what actions will take place following publication. And I would imagine that they may want to wait till some of the other module reports as well to see how they're all interrelated and interlinked. There are 10 recommendations in all. Not all relate to infection prevention and control, but I've just picked out a couple here where there is crossover with infection prevention and control. So the first is around visiting, restrictions, how we manage that risk. So the intention is there to protect others, but we also have to think about the other social and personal implications of that. Better preparation for fit testing, not just for fit testing, but also for all the consumables and supplies that are used to enable fit testing. And my personal view, and it is a personal view, is that fit testing is not the responsibility of the infection prevention and control team. Now, there are multiple duties that infection prevention and control specialists take on because we can see that interconnectedness and the importance, and we want to make everything safe. But this is about instilling boundaries and others taking responsibility for the delivery of care. There are also recommendations around the systematic collection of data for deaths of healthcare workers during pandemics. That was very weak during the pandemic. And then also recommendations around psychological support, which I will come to shortly. So what about learning based on findings? So in an inquiry, you will have recommendations made, but if you actually read all 404 pages, which sadly I have done, you will find that there are findings embedded throughout the document. And actually the findings are more relevant to day-to-day practice than the recommendations, which are broad and made to government. So if you do read the inquiry, and it's one of the things, as I said at the beginning, that you can use to support your revalidation, reflect on the findings that are written. So the findings will be familiar to many of you. So we've had multiple discussions over the years around a lack of evidence. I remember the jokes that came out, I can't remember how many years ago now, about no evidence that jumping out of a plane without a parachute would actually kill you. So there was an article written in the BMJ around that. So we've known the issue around a lack of evidence for many years. Where there is no evidence and when we're dealing with a particular instance like a pandemic or a large outbreak with significant effect, then caution is what we need to do. The value of multi-professional liaison and expertise is one where we focus on the translation and implementation of infection prevention and control guidance into practice. It's very different in a mental health setting, to a prison setting, to a community setting, to a hospital setting, and we have to consider all of those. The hierarchy of controls, not as a linear process, but as a dynamic process, and the unintended consequences of interpretation of language around the hierarchy of controls by managers, by individual healthcare workers, and potentially by politicians or others, is something that we need to be mindful of. And then the importance of easily understandable guidance that resonates to all practitioners in all healthcare settings. So some practical learning. an under-resourced workforce will compromise infection prevention and control. This is well known. There are many studies. The RM forecast study is the big European study, is the one that I'm most familiar with, that demonstrates missed episodes of care when you have an under-resourced workforce, and that means IPC. It means hand washing, it means documentation, it means drug errors, it means all sorts of things, all that relate to patient safety. The provision of adequate PPE, taking into account inequalities, face shapes, people losing weight, ethnicity, all these issues in addition to supply challenges. And we desperately need good research that will support us to understand not only what type of respiratory protection works best in which circumstances, but what is most acceptable to our patients and between teams that are working with each other. We have many nurses working who need to lip read. We have to take this into account. And then the importance of moral distress for those involved in any response, everyone that is involved in the response in all care settings. But we did have learning, and where did the learning go? We knew from the Ebola incident in 2014, when a healthcare worker acquired Ebola in a hospital in Madrid, that many of the issues that have been identified in the COVID inquiry were actually relevant at that time. We met, we wrote a report, we fed back on the need to have the adequate PPE that actually fitted the size of the healthcare workers, the education of healthcare workers, the need to collaborate and to educate and involve those that were delivering IPC in the actual development of the educational packages to make sure that the language was relevant in different care settings. And they also spoke to us about stigmatisation, which was and has occurred in many incidents as they evolved. And this was particularly pertinent for the IPC nurses who found not just themselves but their children stigmatised in social settings. So we do need to understand the experiences not just of frontline staff, and that in itself is a very inflammatory phrase, because many infection control nurses and procurement nurses during the pandemic felt left behind because they did not feel classified in the same way as staff that were providing direct care. So even the term frontline nurse or frontline healthcare worker is difficult. But Mason et al. Have undertaken some global survey work to understand the experiences of infection prevention and control practitioners during the pandemic. And this is really, really important. It's essential for planning, future pandemic planning, but it's also essential now in terms of catharsis for staff that were involved, that found themselves in extremely difficult situations at that time. It's important to explore cultural divides, as I said, and to look at what this means in the future, to use that learning to move our profession forward. There are also a number of non-IPC inquiries taking place at the moment. And when I looked at a summary from the legal team that I work with, it struck me that there were many issues pertinent to non-health related inquiries that would impact on the delivery of health and care. So there is crossover. Now, these reports haven't been published yet. These are just emerging themes from evidence sessions, and they include inquiries such as Thirlwall and Lampard, but also the Southport inquiry. So for me, it speaks for a need to reflect on wider aspects of where IPC fits, how healthcare is moving forward, and how we enable infection prevention and control in practice, giving the learning from these other inquiries. Now, just very quickly, I wanted to touch on a presentation I did in 2004 because we have 2024 because we have so many nurses in the audience. So if any of you were here, I was asked to speak about the nursing contribution, the value of the nursing contribution to infection prevention and control. At the time, lots of discussions around infection prevention and control, having more practitioners that are non-nurses, that provide absolute value to teams. But what was it that made nursing unique? And it also followed as a result of some tension between different nursing roles trying to put change in practice. So this was the reflection from my colleagues when I went to them and I asked them, what do you think are the priorities in infection prevention and control? And even me asking that question showed that I was thinking about something completely different that they were thinking about. And this is what they wrote. And all this speaks to professional nursing practice that is as relevant then as it is now. So this was thoughts and perceptions from nurses to nurses. Frontline, shouldn't have said that, healthcare workers working directly with patients want to practice good infection prevention and control. So I reflected on the responses in 2024, and this was what I spoke about at that time. So infection prevention and control is more than words in a policy or in guidance. Increasingly, we're going to need to learn new skills and to evolve. And I think this will naturally emerge in terms of what the speciality is and how we actually practice. Infection prevention and control is more than bed management. It is absolutely critical we have these relationships with staff, with managers, so that we can provide that advice when needed to avoid issues such as Jean has described. So where does this lead us now? In summary. So 3 pictures here. The first one, unapologetically, a holiday snap from the Lionsgate Bridge in Vancouver. And for me, infection prevention and control is a bridge connecting that technical knowledge and those skills with practice. So the knowledge doing gap, nothing new there. But what is important is that you look at the bridge from different views. And when I was over there, because I didn't see my son for 5 years during the pandemic, which is a significant amount of time, he said to me, go underneath the bridge and look at the bridge from a different angle. And that's what infection prevention and control needs to do. The second image is one of an overtaken car, and this relates to Jette Holt's presentation again in 2024 here at NOLEX, where she talked about the role of guidelines and how to implement and adjust guidelines in context situations. So it's absolutely appropriate to overtake on the road at times, providing it's necessary, providing it's safe to do so, and providing you revert to driving in the correct place after you have overtaken. And we need to teach our staff how to use guidelines appropriately, not just get the correct content in place. And then the last one is around psychological safety. Now, psychological safety is something that is achieving far more prominence and is definitely needed. It's a core element of patient safety. So this is around ensuring that infection prevention and control professionals and broader healthcare workers feel safe to express ideas and concerns openly. We all have questions and we should all feel comfortable to ask those. We need to be comfortable and learn to recognise our mistakes and challenge professionally without fear of consequences. If you want to know more about psychological safety, my colleague Stephen Jones will be in the foyer at the RCN stand, and we have lots of information on psychological safety on the RCN website. So psychological safety, a core component moving forward. To close, in the words of Sir Ian Kennedy, who wrote the foreword to the investigation report. He reminds us that an awful tragedy took place in between 2003 and 2004 at Stoke Mandeville. There's an absolute need to place the safety of patients, and I would say healthcare workers, at the forefront of the agenda of healthcare. And safety can never be allowed to play second fiddle to other objectives that may emerge from time to time. Thank you.